Dr. Barlow couldn't be with us today, so you're getting a more orthopedic view of antibiotics than you might otherwise have done. And it kind of follows on from what Hemant said, really. So I think I am more old school in how I debride. I still very much try and avoid segmental excision when possible, but I will do a very gradual debridement, and I will keep debriding until I'm very happy. I've got a really sort of nice, healthy bed. I've excised all the non-viable bone. I've got rid of all the infected, nasty-looking granulation tissue. I'm getting a really good clean out, really good wash. And those of you guys who've worked with me, I think I'm quite a good surgeon. I think I'm, and Liz is laughing, but it's only arrogance if you can't back it up. But no, I think I'm good, and I spent 2 years training in the infection unit in Oxford, so I've done this quite a lot. And so when I get to this point at the end of all of my debridement, and I've washed it with litres and litres of saline, or use your irrigation fluid of choice. Can I have a show of hands? So how many people here think there's still dead bone in that very extensively debrided, beautifully done surgery? I can take it. It's all right. Okay, there's a few. Any planktonic bacteria floating around in there? Any fragments of biofilm? Yeah, the answer is actually option D. So absolutely, all of that's still there. As good as I can do, I will never succeed in getting rid of everything. And I'm quite happy to admit and own that. And I think that's why, in the early days of surgery, this is 100, 200 years ago now, surgeons would lay open wounds, they would let the pus out, and the patient would die a few weeks later. It was only really when Lister came along with his theories of surgical asepsis, and particularly when Fleming discovered penicillin, that we actually started to turn the tide and actually reduce surgical mortality. Because now we've got something to fight back with. Now any residual bacteria that I haven't been able to get rid of, we can actually do something about. And obviously, since then, over the last 100 years, there's been many classes of antibiotics that have been developed, acting on all different parts of the bacteria itself. But when you do that prescription for your antibiotic, so you prescribe your oral flucloxacillin, just have a think, what actually happens? You've done your prescription. There it goes. What's next? So what are the barriers between that pill getting from my mouth into my infected manky diabetic foot? I don't have a diabetic foot, but imagine. Someone from this table, do one of you guys want to pick up the mic? Hamza, go for it. So the pill's gone in there. What does it have to fight through to actually get to where we want it to be? Because it needs to be in my manky toe, or.
So it has to go down into your stomach.
Yep.
It's got to be digested.
Yep.
Deal with the environment in your stomach.
Yep.
Then goes into your intestine, will be kind of absorbed into your bloodstream, and then at that point circulates through your body.
So what can affect that absorption? Just stop there.
So.
This is medical school. You did do it a long time ago, but.
So, I guess your diet in general.
Mm-hmm.
If you have any kind of systemic illnesses, anything that would affect gut absorption, so diabetes,
Yeah. So they have to get through your stomach, which is a very acidic environment. Some antibiotics cope with that better than others. So some of the early penicillins, like penicillin G, half of it goes just from reacting with the acid before it even gets to your intestine and has a chance to be absorbed. If you've got food in your gut, it probably will affect your absorption. If you've got bowel conditions, if you've got ileus, if you're unwell. If you're septic, what's the first thing that your body does? Well, it redirects blood away from there and to more vital organs, so actually your absorption goes down. So yeah, it's a problem getting in. Then you said it gets into your circulatory system, and it has to pass around. So it has to go through your liver, get through first pass metabolism. when you're unwell, your body is prioritizing other bits to your toe, because your toe's not important compared to your brain or your heart. I mean, orthopedic surgeons might argue that. And it has to be distributed across your body fluid. So it starts in your circulatory system, but then depending on the antibiotic, on how well protein bound it is, it may distribute into your interstitial tissues. It may distribute across throughout your whole body water. So the concentration in tissues varies from antibiotic to antibiotic. And then, yeah, as you said, it gets to the site you want it to get to, so to the foot in this case. It has to get out of the bloodstream and it has to get into the tissue. So it has to go through the capillary walls, down a concentration gradient. Most of them aren't actively transported. They're going down their concentration gradients. The lipid solubility of your antibiotic makes a difference. How well protein bound it is makes a difference. If it's very highly protein bound, actually more of it stays in your circulation, less gets into the tissue. The perfusion of your tissue is a big issue. And because of all of that, actually, the proportion of that antibiotic that's gone in my mouth, not necessarily all of it, or in some cases very little, will actually get into the affected area. And so if you look at some of our favourite Smarties, so everyone loves flucloxacillin as an orthopaedic surgeon, and we give it all the time, but it's actually one of the worst ones for oral bioavailability compared to some of our other options. Then when it's in the systemic circulation, the proportion that gets into the actual tissue, again, is very small. So some, with our Fluclox, very little of that ground that I've put in my mouth is actually going to get to my toe. And that, I think it's worth bearing in mind, and Prof mentioned this earlier, that's in normal bone, so that's in normally perfused bone. The diseased bone that we're treating will be less perfused than that, so we don't have numbers, but it will be worse. So because of that, systemic antibiotics certainly have a significant limitation in how well they can treat bone infection on their own. And yet that's what we used for decades and decades. We've mentioned biofilm already, but so that's this response that the bacteria make to interacting with inert surfaces. So they form this slime. They change their gene expression. They change how they're multiplying, and they become far more resistant to antibiotics and to your immune system. What we want to try and fight that is early on, after your surgery, a very high level of antibiotics right there in that operation site to impede further biofilm formation. And as Hemant said, you will still have some devascularized bone, so we want to stop more biofilm forming on that bit that we've missed. And I mentioned this already, but yeah, so in poorly perfused tissue, actually very little drug gets into the poorly perfused area. But if you start using antibiotics in a different fashion, if you start putting them locally in your wounds, then we can change the game to an extent. We have been using local antibiotics for decades in orthopedics, but mostly it's the arthroplasty guys, and it's using PMMA either in cement around your hip prostheses, or when they're doing infected work in PMMA beads or spacers. But it is something we use in the bone infection field, the wider bone infection field as well. And this is actually a reasonably recent study that showed that if you wanted to generate high enough concentrations of gentamicin to treat bacteria that's still in biofilm, it is technically possible, but you need an extremely high concentration in the tissue. To do that systemically would have massive toxic effects. The patient wouldn't survive. The bacteria would be gone, but so would the patient. However, with PMMA beads, they were able to deliver that high concentration. The downside to bone cement is it's cement, so it stays there forever unless you go back in and take it out. And we don't. When you've got an area of infection healed, you don't really want to be opening that area up again to take out the cement and hopefully try to get it to heal a second time. We did that for a long time, probably up until the late 2000s, I guess. And at that stage, absorbable antibiotic carriers became sort of available on the market, and there's been a real expansion of them probably in the last 10 years. They're now very widely used. That was another similar in vitro study. This is one such absorbable carrier that I use a fair bit, Cerament. They are one of our sponsors. Go and say hello to them. But there are many others available. There are other ones also sponsoring us today, so I'm not going to show bias. But they just happen to have given me some quite nice slides that I'm using. So what these antibiotic carriers do is when you finish your debridement, you finish your wash, you can put them into your bone defect. They'll fill the dead space, so it stops it filling with blood, with hematoma, which would act as a culture medium for bugs. And they would release over the first couple of weeks an enormously high concentration of antibiotics, so either gentamicin or vancomycin or a combination of the two if you mix them. That high concentration is, come back, pressed the wrong way. It's considerably higher than you get just from PMMA beads. It's also considerably higher than the MIC and the minimum biofilm inhibitory concentration, at least in theory, according to manufacturers. And I mean, clinical evidence does seem to back this up. It does make a big difference to our infection clearance rates. The other nice thing is that after a few weeks, the level of antibiotic that these are eluting drops to almost zero. One of the downsides to PMMA was that you had this trickle of gentamicin being released for months and months afterwards, which actually was quite good at stimulating the development of resistance. So these give you a really high dose and then nothing, which is kind of ideal for killing bugs and then not generating resistance. And I mean, the real point of this talk is to talk about what it means in terms of our antibiotic use perioperatively. So we do all still use systemic antibiotics for a period in the perioperative period. Two reasons. So one is that we're going into an infected area, stirring everything up. We will be releasing bacteria into the circulation. The patient can become more unwell. We don't really want that to happen. So it is sensible to have some systemic antibiotics on board over that period. But also, we don't know what bugs we're necessarily dealing with until we take samples intraoperatively and send those to the lab. That will take at least 48 hours to get those first results back from the lab. There's a chance that it's a bacteria that's completely resistant to gentamicin or vancomycin or whatever I've put in there. So it's good to at least have yourself covered in case it happens to be some weird resistant bug that this isn't going to work against. But there's been two big studies that I just wanted to spend a couple of minutes talking about before I finish. Both originated from Oxford, but they're both multi-centre studies across the UK and Europe. The first one was Aviva, which is quite old now. It's a decade old, and it looked at data from 26 centres across the UK. It was comparing the old-fashioned practice of what orthopods always used to do, which was keep a patient on 6 weeks of IV antibiotics following any bone infection debridement, versus switching to an oral form within a week and sending them home. So obviously from an economic point of view, it's far preferable to have your patients on oral antibiotics as long as that isn't going to be harmful and cause recurrences. And essentially they looked at the primary endpoint of infection recurrence after 12 months. There's no difference at all. So as long as you had systemic antibiotics at the site of your local antibiotics at the site of your surgery, and the bugs that you grew are sensitive to whatever you've put in there, it didn't matter whether they went home on orals or whether they stayed on IVs for that 6-week period. And since then, all of us have stopped using long-term IVs except in exceptional circumstances. It saved an awful lot of money in terms of inpatient stay, in terms of OPAT services, having patients having to come back for daily injections with the OPAT nurses. And there was no difference to outcome. And actually, there were fewer side effects when you weren't using IV antibiotics. The logical next step for that is this trial called Solario, which has finished recruiting at the end of last year, has now been written up. I don't think it's actually out in print yet. But essentially, this was again a randomized multi-center study across the UK and Europe. So it was fairly pragmatic. So you had to have used a local antibiotic carrier at the site of your debridement. You had to have removed the metalwork. So this wasn't for DARES. This was for ones where there wasn't any implant left in. You had to have closed the wound, so you couldn't be vacuuming it. You had to either be able to close it primarily or plastics to do something to get it closed in that first sitting to be eligible for this trial. And patients were essentially randomized either to a short regime where they had to stop all systemic antibiotics at a maximum of 7 days post-surgery, or the long regime where they continued as normal, had to be at least 4 weeks, but most places were doing 6. And it was looking at the treatment outcome and recurrence, particularly at 12 months. As I said, it's not yet out in print that I've seen, but the sneak preview is essentially there's no difference again. So recurrence rate in the long arm, where patients were being given 4 to 6 weeks of antibiotics, was about 14% all in all. In the short arm, it was about 11, so no statistical difference between those two. There were fewer complications related to the antibiotics in the short arm, as you'd expect, because you're not giving this long course of antibiotics, so you don't have time to run into as many side effects. And the relevance to today, which is quite nice, is something I'll come on to later, is that actually this did include a fair number of foot and ankle cases, unlike a lot of published infection work in the literature. So about a quarter-ish of the cases in both arms of the trial were foot and ankle. About a quarter of patients-ish, 22 to 25%, were diabetic. I haven't seen any subgroup analysis. I'm sure that will eventually come about, though the numbers will be relatively smaller, I suppose. But this is relevant to foot and ankle and diabetic infection as well, I think. So I think that's probably an important point for today, unlike many other trials which don't have a lot of foot and ankle in them. Since we've seen the results of this, we have started changing our practice in Hull. So we are now doing short course antibiotics where we're happy that we've got a sensitive organism that we've treated with an appropriate local antibiotic. So far, touch wood, we haven't seen any problems from doing that. I think during the recruitment, when we were recruiting for this trial, you get a bit nervous stopping antibiotics early for the first few cases, but actually we didn't see any problems during the trial, and that's continued to now. So I think it goes to show that local antibiotics are really a game changer in this field. And from the point of view of both patient outcomes and antibiotic stewardship, should hopefully be a very, very useful thing for the long term in our field. So in conclusion, bony debridement is good, but it's never enough. So we do need to use antibiotics in sensible ways. Local antibiotics don't replace doing the surgery properly. They don't replace taking good samples during your surgery, because you still need to make sure that you find out what bug it is and make sure that bug is sensitive to the antibiotics that you've put locally. But if you confirm that, I think systemic treatment can be tapered much shorter than it has been in the past. And yeah, this will be, I think, continuing to be an expanding field. That's any questions on that? Go for it. Fire away.
You said that systemic antibiotics are based on cultures. In terms of what your local antibiotic choice is, does it
Yes.
not matter too much? Because I think I've heard somewhere that even if you've got resistance, you can get a higher concentration gradient to treat the antibiotic at the bone, or is that not true? Or do you
So yeah, so the local antibiotics. I mean, the ones that come sort of pre-made, you have a limited number of choices. Gentamicin is by far the most commonly used local antibiotic worldwide, and it has been because of bone cement, effectively, for many decades. It's a really good antibiotic. Bugs are slow to generate resistance against it, which is why we've gotten away with using it in bone cement for so long, I think. And it's pretty effective against most bacteria. And as you touched on, so even if you have an intermediate level of resistance to gentamicin, certainly theoretically, in very high concentrations, it probably still is sufficiently bactericidal that it will work. That said, so certainly in the trial, and this is here and when I was working in Oxford, when there was gent resistance that came up on the sensitivity, we did continue a 6-week course because we didn't quite dare take that leap at that point. About that resistance, we'll have to see. Also, I mean, some species of bacteria are naturally more resistant to gent, for example. So halfway through, we started actually using vancomycin mixed in with the gentamicin pretty routinely because quite a lot of the streptococci that were growing were gent resistant. And I think Martin McNally was getting quite annoyed that these patients kept getting excluded from the trial. So possibly because of that, we changed practice and used a mix of vanc and gent, which I think is fairly standard now. I think most centres are doing that if you use Stimulan or Cerament or one of the other carriers.
Do you mind if I just add to that?
Yeah.
I'm a microbiologist.
Hi.
So I'm a microbiologist from Sheffield, and I think with your gram-negatives, you want to be a bit more cautious with the gentamicin resistance because although you're picking, I know the Oxford lot are very much like they've done studies and, you know, even if it's gent resistant, they're quite happy because of the local concentration. I think we'd probably err on the side of caution because although you're picking a gram-negative and you've done your susceptibility testing, you're assuming that all the sort of antigraft ratio, whatever gram-negative, they're all the same, but they're not necessarily all going to be the same. You're going to pick up the dominant one, which is growing. You may have colonial differences, which mean that you may have other gram-negatives that are there, that the gentamicin resistant one, you might get some which are overcome by the high level of gentamicin, but some that are not, so you may get relapse infection. So when we approach it, we will use more broader spectrum antibiotics. But again, that's your microbiologist that you're having a discussion with in the local school of thought. Mm-hmm.
So yeah, I think that that trial can't conclude that you can ignore resistance, I think is what they would say. And it's probably also relevant to this afternoon as well, because I think as you go further down the leg, as you get towards the foot, actually, the number of cases that are polymicrobial that you find there's multiple bugs in there goes up and up the closer to your toes you get, roughly speaking. So that's probably relevant. Volker, go ahead.
Thank you very much. Very nice talk.
Thank you.
So how do you deal with the so-called culture negative infections? So you have confirmatory signs of
Yes.
The infection, but you cannot grow the marker organism. You have used your local antibiotics with gentamicin, just vancomycin, or one of them. And how do you then treat them systemically?
It's a very good point, actually, because I haven't got those slides. I'm not sure if I got them. It might be later on in this. Hang on, here we go. This wasn't set up, by the way. So this was some work that Maria from Oxford did. This was in big cohorts from Oxford. More than a quarter of cases, you don't grow anything. And that's sort of standard. That's the same. We found the same in Hull as well. It's difficult at that point because then we would still assume they're infected if we have other signs of intraoperative purulence, if there was a sinus, for example. So our practice, we haven't as yet sort of come across one of these actually since Solaro came out, I've got to be honest. I think partly because of what we were talking about and the high local levels, I think we would probably still be happy stopping at 7 days, but I know that is a risk. That's very much a judgment call, I think. I don't have a sort of any scientific basis for an answer to that, because those are the ones you just don't know, I think. What do you guys do?
I think we would also like to stay on the safe side, and we would go for the 6 weeks. 6 weeks of systemic antibiotics. Orally.
Yeah.
So just something new is coming out is about the calorimetric measurements of the bacteria. And what they've done is they look at the temperature and what they emit, and depending on the infection, your heat signal might change. And so what they're doing is, it's not out and it will take some years, but the severity, the type of the bug, there's a possibility with the data coming out that there's a possibility we need to identify the bug and the severity of infection. Cultures still we can't, but that's something in culture negative might be more useful in time.
But yeah, question that, go ahead.
I was wanting to ask you about the stimulant.
Yes.
What you're using, so we obviously get quite a lot of wound liquid with it. So what, does it depend on how much is in, or how big the infection is? So how
The leakage, you mean?
how much leakage the stimulant would produce? Is it just the stimulant?
It is, so it's a very, very fair question. It's one of the things that I think upsets people about local antibiotics, and whenever I started using stimulant, we saw a lot more wound leakage. And it's the same with other sort of rapidly absorbed carriers as well. I think it depends on two things. I think partly it's the volume of stimulant that you've used, and it's where you've put it. So if it's well contained in bone, if you have a sort of medullary disease and you've reamed out a canal and it's all fairly well contained within the canal, and you have a really good, it's really important when you're closing these infection cases to try and get sort of a really meticulous multi-level closure. So you're closing each layer of tissue from the inside out to try and seal the local antibiotic in. So the leakage depends largely on that, how contained, so the volume of local antibiotic, how well contained it is in bone, how well contained it is by your soft tissue closure. Equally, I think it's important not to be scared by wound leakage after stimulant. You sort of have to expect it. And if for the first couple of weeks, if you're getting a reasonable bit of wound leakage, as long as there's no wound breakdown, our practice is certainly just to watch and wait for it to dry up. That doesn't mean that there's a reinfection. It's just that's the stimulant producing an awful lot of liquid and more than is contained within the tissues. It's not a marker of how bad the infection was or whether infection's coming back, to my mind anyway, I think. Is that reasonable? I don't know.